Thank you. You as well. All right. So managed to set expectations pretty high, I think. So all I can do is just not meet those, right? So that's okay. You know, I've been all around the country now, and it's been interesting because when I started, I was just an ER doc, right? The same person who has, ADD and wanders from room to room and can't remember the next thing that they're supposed to do, but they just we do and we move and we do and we move. And it was a specialty that was really measured very much by, and is measured, I still clinically work in the emergency department, and it still is measured by the number of patients you see, the procedures that you do, the calmness in a code. It's that more so than the humanness in your voice, the connection with the person in the room, and even the connection with the people that you work with. And I think, unfortunately, that's happened in really all aspects of healthcare. I've been the chief of pain medicine for a large health system with 12 hospitals, and which means I had to answer to patient complaints about pain control. And this was back in 2010 to 2014. Kind of at the height of this whole scare and peak, and so I was answering a lot of those complaints. And when I would talk to the other providers, what I identified was someone who was pretty done, kind of burnt, frustrated, angry, and honestly, people who felt powerless to work with these patients. And then I recognized that moving from the emergency department to addiction medicine and pain medicine and complex care treatment ultimately was because those patients destroyed me in my early career emotionally. I hated my job. I got to the point where I dreaded showing up to work because of those patients. And I almost left medicine because of it, to be honest, because I felt like I couldn't do this job if I can't deal with the people that I'm supposed to. So what I did is what a lot of us do is I laid down the law. I set the rules for how I was going to interact with those people. So my first attempt at this was walking into the room of the person I had seen 10 times in the last 6 months and saying, look, we know each other. You know I'm not going to give you opioids. What can I help you with today? Pretty human, right? Very kind, very empathetic. I was the most complained about emergency doctor in the health system, and I was in the top 1% nationally from the group that did our survey. And the sad part is that was at that time in my career a badge of honor. It was, I'm the only one saying no to opioids. And I've never been a proponent of opioids. It always didn't make sense to me. But at the same time, the way in which I said those things was brutal and mean, and was really inwardly focused on protecting myself rather than treating a patient. And so as we start to walk through some of the neuroscience, talk about addiction as a disease. We're going to walk into some trauma conversation a little bit, and then talk about how that translates into the systems that we work in, or more realistically, how it doesn't translate a lot of times. And then hopefully have a dialogue at the end of this for deep, complex questions. And so I'm going to try to leave plenty of time for questions so that when you have them, I can not only answer the question, but I can take it 4, 5, 6 layers deep, all the way until I lose everybody in the room with the level of nerdiness that I can put on that. So we'll start with, these are the things that we want to do: neurobiology of addiction, different medications, think about screening, assessment, level of care determination. I think this is something that's lost. We'll talk about the disease, but understanding, well, how do we identify who needs treatment and what that looks like and how it is? Because I've found as I've gone out, I assumed that people understood the difference between screening and assessment. Most doctors do not, yet we do it every single day in the specialties that we're trained in. So screening for a heart attack is somebody coming to my emergency department and saying, I have chest pain, right? That's a screen. And then I assess them. I do an EKG, I look for a troponin, we take a history, we do all these, and then from that, we determine level of care. But for some reason, what happened in addiction medicine is that we said they have addiction, they need to go to residential treatment. There was like this disconnect between an assessment piece, and we missed it in how to determine it. So I'm going to talk a little bit about that to educate you. Tomorrow, I'm doing a deep session on the ASAM criteria and what that is, but today I want to touch on it a little bit. I don't have any disclosures, so I've never gotten a dime from pharma, and I'm pretty sure after all these lawsuits are done, they're not going to ever want to hire me for anything. And then from device, I do interventional pain, or I did interventional pain. I decided one less board is perfectly fine with me at this point. But I never got any money from device companies. I have grants with the Department of Healthcare Services in California. Right now we're putting addiction screening treatment in the entire prison system and 40 counties worth of jails. And we're also doing editing a perinatal toolkit with Stanford right now that'll come out in January for everything from prenatal to the follow-up visits with pediatrics and that whole package of NAS work in the middle with that. And then we're working through some county process improvement stuff with that. So those are the grants. But I work for Health Management Associates, which is a Medicaid consulting firm, and I get a salary. So those grants just come in, and I just get paid. So like on a regular basis, luckily, and that's it. So I want to start first by just setting the stage to understand that you guys live in a place that has some distinct cultures. You have a native population, typically within the American Indian population that lives here. You have people from Hispanic origin. You have people who were forcefully brought from other lands here a couple of hundred years ago and made to stay. So as we start to look at the diversities of these cultures, I think it's important to understand how we have not built systems for cultures. We've built a little bit of training around cultural sensitivity, but we're like, I understand your culture, but come get your care in my system. Because we don't change the system to fit the culture. So I want you as a thought experiment, I want you to know about the culture which you're working on, right? Whatever area it is. And that culture could be, I grew up in Texas, and there were cultures of people that looked just like me, but acted very differently than me in Texas. And understanding what that culture is and how they define it. Being sensitive about it, I think we're there. I think we're working on that in medicine at this point. But now we have to build a system to encompass the culture. Right? So the construct that I've used to kind of describe this is what are the 5 things that really define people's culture? Right? And everybody has their own kind of 5 things, but I'm talking about food, about art, about music, about family dynamics. These basic fundamental things that generally get maligned the minute you walk into a hospital. And what you get is a Luby's cafeteria food, so nobody's going to be making, stuff direct from the land and have, an American Indian menu set up for this so that they can eat food that culturally they had. We don't have any people who speak any of the old languages in that setting. It's very difficult. And even if we do, we translate. We don't interpret with that stuff. So these are important things to think about. And the entire work that we're going to do as we build an addiction treatment system, we need to be thinking that as we build this, because we're in the process of building this right now, so we can do this. As we build it, we should build it so that it fits into cultures and can maneuver with whomever it needs to see. All addiction is not the same, right? We say it's a brain disease, and I'm going to talk about, the reward system and the nucleus accumbens and ventral tegmental area. Everybody has those parts. It's like saying a right arm or a left arm, but at the same time, the way in which they get to that point of having the disease of addiction can be very different, which is why we have many modalities of treatment. So if I have patient 1 who had early life trauma, focused mainly on neglect, with the sexual assault early, and then I had patient 2, parents got divorced, they had shared custody, but there was no neglect. In fact, they would just get in like Christmas fights of who was going to buy the coolest gift, I'm the best parent because I spent more money and bought you a better bike. And and then isolation from friends. Right? That's what happens. That's a pretty common thing for people with adverse childhood events is they start to isolate early because they feel guilty and ashamed and frustrated and nobody gets that. And then we have this one with lots of friends. Right? We have a lot of friends and then we have early use of marijuana. That happens pretty often, whether it's marijuana, nicotine, or alcohol. If you had early life trauma, as we get into it, there feels like an emptiness and sometimes a substance can take that place. Sometimes it's a relationship, right? That over-attachment syndrome that we can see in that subset of the population as well. But patient 2 tried marijuana once in high school, used a couple of times per month in college, just kind of hanging out, but nothing big, nothing daily, nothing. If they didn't have it, they didn't have it. We're fine. Patient 1, heavy episodic drinking in early high school. So when she would go out, she drank. She drank until somebody had to get her home. She would black out most of the time. It was a binge effort, and it was usually 3 to 4 days per week by her senior year. And episodic binge drinking in college, I mean, that's rare, right? Nobody drinks in college. I always talked about, I tried really hard to give myself an alcohol use disorder in college. It just didn't take. And I can't, that's just luck, because I had friends that it took, and it took a toll after that. And then we had patient 1, opioids by 19, wisdom tooth extraction, first opioid, continued chronic pain, a couple of car accidents that she showed up to the emergency department for when there were no car accidents that had occurred, but complained of injuries that had occurred, that she had gone home and started hurting all over and came in, and we obliged her. Heroin by 22. This one went to medical school. Looking pretty good, right? And then I gave him naloxone in the resident call room when I was in attending, going to look for my resident. And so both of these people meet criteria for addiction. They came at it from a very, very different way. And so the one on the right, there are certain legacy treatment modalities that are probably going to be really helpful for this person. Doctors, pilots, and lawyers with 12-step modalities actually have about an 85 to 95% remission rate at 5 years. It's pretty crazy, right? So the data is pretty clear on that. The problem is we cannot extrapolate those data to patient 1. Patient 1 is a whole different neurobiological array of stuff. There's a lot of different things going on in that brain as compared to the other one, because if you have delayed use into adulthood, the injury just doesn't make as profound of a change, and it doesn't really interact with the dopamine system in the most profound way that it can. So keep in mind, as we talk about the neuroscience, when it happens is important. How it occurs and all the precursors to it become important. This is not a black and white disease. It is very heterogeneous. The fundamentals are the same for everyone. What we talk about today with the reward axis is the final common pathway for all addiction, but each substance has its own unique couple of extra things that it does. And each person has some very unique couple of things that they only own. So when we go through this, I wanted to make sure that as we're talking about this, we start with this early life trauma. I didn't really know much about this when I went through medical school, definitely not in grad school for neuroscience and residency. I think when you hear the word trauma, I thought of, I got to put a chest tube in. That was trauma. And I didn't think about adverse childhood events and early life trauma and what that means. So let's walk through some of the science of what happens when somebody has these adverse childhood events that occur. You have the hypothalamus pituitary adrenal axis goes into overdrive, right? So you get a huge bump of cortisol that comes out, and then that becomes chronic, and so the body has to compensate for that over time. And it's not meant to be up for long periods of time. So this is why we start to find insulin insensitivity in the subset of the population with chronic stress. We identify truncal obesity in this population more because it also changes the hormonal axis for how energy is stored in the system. And when we say you need to lose weight, if you have chronic stress and hypercortisol release, it just doesn't work that way. Each exercise burns about half the calories than it would for somebody else who doesn't have that stress, because the body is just deferred for storage, and it will let you pass out from hypoglycemia before it dips into that storage. So it is really recalcitrant stuff that we're dealing with. And when we look in here, the increased norepinephrine from the locus ceruleus, this is a central part of the brain and the pons and the brain stem, and it releases our central norepinephrine. It's indirectly responsible for some of the sleep-wake stuff. It's responsible for what clonidine decreases hypertension from. I mean, it blocks the release of that norepinephrine and thus glutamate in that system. So if you crank up norepinephrine centrally, that can have some profound effects, and a lot of times that looks a little bit like anxiety, skittishness, that kind of hyperactive state with some increased movements that people will have. and then a decrease in dopamine from the nucleus accumbens. And you'll definitely know why that's important as we start to talk about addiction. But if you have this adverse childhood events, the basics here are that it's setting you up for not good stuff. Now, what would we call trauma? There are things that we think about all the time, right? A sexual assault, physical assault, emotional assault, and neglect being the worst of all of those as far as how profoundly it changes the neuroendocrine axis and the remainder of the brain structures. But then when we look at other things that we used to not realize that we would call trauma, discrimination, that's trauma. Individualized discrimination, or what we still call stigma, by the way. It's not stigma anymore. It's now discrimination. We give them a diagnosis or a label, and then we completely, as a community of people, refuse to give them evidence-based care. We've made that decision. We know what the evidence is. We still haven't gone in on this wholesale. So that's discrimination. And so that discrimination for patients with the disease of addiction really becomes ongoing trauma for them. And then chronic poverty also has the same brain changes that we see and looks no different than chronic emotional trauma for patients. Even if they had a stable household, but if they didn't know if the meal was going to come or they were going to have a roof over their head consistently, that increased that HPA axis and then changed how the dopamine axis reflects, and then also how the central norepinephrine is released. So these are all things that we have to think about when we see patients in general, because if they've had all of this, how we treat any disease, let alone something as difficult as addiction, has to change. And it has to change in a profound way. But the cool part is it only changes a little bit of our language, which is the start of this. You don't have to completely blow up the system, but we have to actually be nice in an evidence-based way, right? That's called motivational interviewing, and it's true empathy and some cognitive behavioral therapeutic approaches that can be really helpful in that. And I didn't truly understand all of this, and my therapist that worked in my clinic, she's done this for 20 years, and she would tell me all the time that I didn't understand what I was talking about. So that's why I went and got certified in trauma CBT, so that I could say, I also have certification. And she said, it doesn't matter, you still don't know. But I do know these things. I do know that we actually have identified the structures in the brain that take a hit with trauma. And these things take a hit predictably and consistently. So when we've looked at this, and this is a combination of animal studies, a combination of a number of different fMRI studies and PET CT studies that have happened over the years, most of these done at NIDA, Northwestern, MIT, and then 2 of them at Harvard. Stanford has done 4 of them at their neuroimaging pieces. So it's all of those kind of wrapped into generalizations. I'm happy to spend an entire hour just talking about what happens to the hippocampus, but the basics of it is that past event memory has little or no emotional context, and that increases the trauma. And so when we look at this, and the corticotropin releasing factor equals the decrease in development of the dendritic spines, what does that mean? Less memory capability. Early life trauma takes away your ability to store memory. It decreases your hard drive. And it does it because you're also not able to access what we call cross memory as well. So I may have a memory of something, and then I'm able to connect it to another memory of something completely different and make that connection, and that becomes an idea. Those things happen pretty regularly when you have these cross branches of the dendrites, because different parts of the brain can kind of fire and set off other ones, and in a productive brain that works really well. Unfortunately, early life trauma, all of those things I mentioned affect this. Neglect affects it more profoundly than the rest of them, but all of those things that I mentioned affect it. The amygdala, the emotional brain, it has more connections than any other single part in the brain, both coming into it and going out of it. It is a really important structure, and the central bed nuclei is responsible for emotional memory, and the lateral bed nuclei houses the fear response. This is really interesting. What is the fastest neuron that goes to the amygdala? What gets information to the amygdala faster than anything else? Your eyes, right? The optic tract has a rapid bypass. It has an expressway to the central bed nuclei, but it actually goes through the fear center before it'll lay down that visual memory. So emotional memory are those memories that are our strongest, happiest and sad. They can be extreme, And at the extreme and negative, we call that PTSD, because what happens is the emotional contextual memory that that person has laid down in the central bed nuclei of the amygdala now has a really strong attachment to the fear associated with that in the lateral bed nuclei of the amygdala, which means that it sets off that fear response with a sound that sounds something even similar to what they had heard, or a tone of voice, or a situation. And this can happen also for drug memories from the positive side. So when we start to talk about how we lay down default behavior, which we'll get into in a second, you have to look at the things that are the scariest lay down there, but the things that are the most profoundly happy also lay down there. And when you take drugs that do change the way in which the reward system sends out dopamine, you can lay down some pretty significant positive memories if you use methamphetamine, or if you drink alcohol to intoxication, and those positive memories can get triggered easily, just like PTSD memories can. So that's important to understand that as that comes in, I see a shadow, I freak out. First, that freak out is that rapid expressway to my lateral bed nuclei of the amygdala, and then if it's something of context that I need to remember for safety, it lays that down in the central bed nuclei of the amygdala. So these are important structures. Orbital frontal cortex, trauma decreases the gonadotropin and mineralocorticoid receptors. So when you do that, those modulate the sensitivity of this part of the brain. So the orbital frontal cortex, which assigns value to a reward, meaning me having a moment to go play catch with my kid is very valuable to me, right? I travel a lot, so we play video games together. So I'll get on and we play Apex, which is just a random video game, but we play together. So he's on the other side and I'm here, and I get more information when he's playing and we're playing together than I ever do when I'm like, how was school? He's like, it's fine. What'd you do? Stuff. That's like the most I can get out of him, but when we're playing this, I can ask, and he's like, oh, yeah, in second period we did this, and blah, 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 and I can get the whole thing. And that's very valuable to me. I look forward to those things. In fact, I'll put off doing homework in order to actually get some time with him to be able to do that. And so those valuable moments are stored there. And that's how we assign what is important to me right now, especially when you have to make a decision between A or B. And then we get an anterior prefrontal cortex, which integrates input from all over the brain, and that's what helps us to really make a decision about stuff. So this is an important piece. We have other ones. This is also an important one that I never knew about it in this context in neuroscience. But once I started digging into the research around this and the literature, what I found was that the lateral habenula is what creates our learned responses to a rewarding stimuli. So your default response. So my default response when my kid goes, hey, Dad, you want to play a little Apex, is yeah. And I'm like, crap, I'm in a meeting. I can't do that right now. But my default response is yes. And that's the same thing we would do for anything else that we have that cool opportunity to do. So if you like to travel and somebody calls you and goes, hey, we got a trip, we're going to go to Gibraltar, it's going to be great. Yes. That's that default behavior that we see. And in the periaqueductal gray, which is the production of our own endorphins, is actually one of the things in our brain that helps us to modulate mood in general. And when that happens, the location of modulating aggression and defiant behavior. So as we beat that area up, not only does it not do good with pain anymore, but it actually really explains why people with early life trauma can have these peaks and valleys of aggression and then basically isolation on the other side, because the periaqueductal gray cannot modulate our own internal opioids to stabilize that. So instead of it being a little bit up and down, it has these peaks and valleys that go with it. So if we look at all of these pieces here, so we look at the medial prefrontal cortex, you can see all these signals really moving all the way there. So let's give you a traumatic experience example. So let's say my patient grows up in a household that on Thursdays and Fridays when Dad gets home from work, those were bowling nights, and he comes home and he's pretty lit, and they basically always get abused at that point. That's just kind of the routine as a Thursday, Friday beating. And this is a patient of mine. And so over time, you didn't know what to do at the beginning. It's just a kind of crisis and freak out. But then you start to figure out what are the things that keep me from having that happen badly. Is it maybe I hide? And so I isolate, and my response to this crisis or this fear is flight. And so I flight and I hide in there. Or maybe it's because it's dirty in the house and he gets angry. It takes that one thing to set off. So you know it's, oh my gosh, it's 4:45, so I got to get the house totally clean so that when Daddy shows up, it's no big deal and it's not going to be okay. Or maybe it's just having dinner ready. Whatever those little pieces are, we'll set that in. And you will see that as valuable to you because it saves you that physical pounding that you're going to get. So you will actually then make that the default behavior to that Thursday and Friday night. So let's say the thing that creates this is if you're a female that comes in and dad's being physically aggressive toward you, if you become more attached, more loving to him right away. Oh, it's so great to see you, Dad. I'm so happy you're home. And you become very attached to him, overly so. And that is the default behavior when fear comes on. And so over time, that becomes the default behavior to the point where it is just the behavior that happens anytime you experience that. Have we seen that in some of our patients who overly attach to the abuser? If you dig into those patients, what we identify is that that was their safety mechanism back in the day, and that was their default behavior that was learned, and they attached value to that behavior because they found safety in that. What about the adolescent male in the same situation that he finally got big enough to fight back, and the thing that allowed for him to be safe was an immediate and rapid response with aggression. This immediate pushback, puffing out the chest, straight to fight. And then that becomes a valued response. And it also becomes the default response to that behavior. And then we identify someone who becomes an abuser. So these are the things that we identify. And we're like, well, how do these people find each other? I mean, how common is like, how do they always seem to find each other? Well, it's because those are the places in which they had optimally wired their brain to be comfortable. And so they identify that environment as a place of safety, but it's an unconscious identification of that. This is not a pros and cons list. It are these parts of the brains that are being manipulated over time. And so if you get an orbital frontal cortex that gives you a different value proposition for something, an incorrect value proposition, and then you have a lateral habenula that gives you a default behavior that's a maladaptive default behavior, and we couple that with an increase in norepinephrine or excitability from the locus coeruleus. We couple that with the periaqueductal gray not calming that down. And then we couple that with a decrease in dopamine from the nucleus accumbens. And then all that information goes through the amygdala into the medial prefrontal cortex, where we make these really complex decisions. If input is bad, output is bad. So if the signals coming into the medial prefrontal cortex are all maladaptive or wrong, in a sense, the output will always be wrong. It's doing math with the wrong numbers. And so as we talk about this in computers, garbage in, garbage out, right? This is the data science 101. So the message coming in is messed up to the point where if you have all of these things that are, happening, what you end up with is a brain that is not functioning properly from a normalcy standpoint, the way in which we would talk about living within the confines of emotional constructs and communities and people around you. But what you find is one that is a finely tuned machine to be in an abusive situation. And that is how they have modified over time. So the really scary part is that these parts, like the orbital frontal cortex, as it starts to assign value to things, it can be hijacked really quickly with other things that allow for it to assign really high levels of value. Like, I don't know, when I'm intoxicated, I don't feel all of this guilt, shame, and horror from all of the trauma that I have. I see that as very valuable. I see that as the safest I've ever felt. It's amazing how quickly then that value of that substance now starts to overtake me spending time with my kid. Me, doing something meaningful for a patient. Those are the ways that the brain starts to manipulate over time, so that if you've had early life trauma, and I in our clinic, we took 7 counties worth of referrals for pregnant and parenting females on a controlled substance. We stopped doing ACEs screens because they were all severe. It was just a wasted screen. We switched to other tools that we could get more valuable information because we just had to assume everybody had had trauma, And 88% of those, of the few hundred, 600 or so we saw, it was sexual trauma. It was a sexual assault that had occurred more than once for the vast majority of them. So we just assumed that. So we would, in our first intake visit, just have that conversation. We normalize the process of that. So as we talk about the neuroscience of this, that should have us thinking about what we should do with our behavior and how we interact with patients in these situations. And we started off with, all right, if the construct is that a male created this trauma for them, what do I have to do to not just set that trauma off the minute that I walk into a room and start to talk to them like a doctor? Right? I mean, because this is something that just me being in the room with them by myself is basically setting off that cascade of events that goes from that medial bed nuclei of the amygdala to the fear center and the lateral bed nuclei of the amygdala. And now I have someone who's almost in a panic state at that point doing their best to hold it together in that appointment. And that was more often than not, especially once I got better at asking those questions about what it is and changing the way in which I interact. So the difference between how we set that off and we don't set that off is I'm not some big hulking figure, so I already have that going for me in this, which is a positive thing, to be honest, if you're working with people with trauma. Being smaller is better, honestly. It also helps with air travel as well, by the way. But I would go into the room and I would always get small. I would sit on a stool that was deliberately lower than everything else in the room. If they had chosen to sit on the stool when they came in, I sat on the floor. Physically, literally smaller. Never with a white coat, never with authority. Never, ever. That is the absolute wrong thing you can do for someone who has experienced this. And what I found is that even for people who haven't experienced this, I am a white male doctor, which is the preeminent level of power innately in our United States of America. I didn't earn that, right? I didn't somehow do 50 years of schooling to be a white dude, right? That just happened. So the fact that that is just a reality of a power dynamic means that this is actually a really good tool for everybody you see. And so just thinking about the way that we take the neuroscience into what we do clinically becomes really important. The other piece is that we have a rare opportunity to show them that not all males are predators, that you can actually create an appropriate attachment, which took a lot of work, by the way, because they by default in general would over-attach. And so you had to make sure that you maintained that appropriate therapeutic distance, right? So I'm a hugger. That didn't occur in those rooms. It didn't occur with those patients as much as I wanted it to. I mean, because I felt like there are other staff that can do that without creating confusion. And so we had to have very deliberate conversations about this, about who is doing that, when is doing that. If we did a procedure, like if I was doing trigger points or I'm going to do any kind of injection, just the active touching of the patient can set off a massive cascade of months of kind of redo work in the behavioral therapeutic space because of this. So recognizing this and that trauma sets up these patients is really, really important. And that's even before we get to addiction. So this is a big bundle of fun. So what does all that mean? So after trauma, we attach value to things that hold little innate value, right? It could be drugs, it could be over-attachment, it could be aggression, it could be, that panic that you heard the car coming down the street on Thursday, and you would have that panic, but it always helped you to get stuff done and go hide and do those things. And so now every time that you hear a car that sounds like a 1981 Buick Century, you freak out because that was the default reaction that you had. So that innate value of isolation, it doesn't have innate value. In fact, it has a devaluation of how you interact with the people around you. And so we can create these new default behaviors to standard inputs, and we have to work on that. That's really what cognitive behavioral therapy and specifically dialectical behavioral therapy is meant to do, which is to create a new default behavior to an input. And that's what the focus of it is, and that's why we have to do those things to fidelity and not say things like, well, we use dialectical behavioral-like therapy. No, it's a therapy. It's a very specific thing. Wrong therapy is wrong drug. So we have to make sure that we apply this very quickly. We set up the brain to be susceptible to drugs because we've now opened it up to anything that offers itself to be valuable, meaning separative from those behaviors and feelings, is now automatically at the top of the pedestal. Sometimes that's a relationship that gives value. And then they become, the ex-girlfriend that follows you to 2 states and leaves notes on the front window. Says, just to let you know, I moved here. That's the experience. So this is, but now I understand. I wish I knew then what I know now, right? Don't we all? But the way that I see this is trauma in my mind is ultimately a gateway drug because it primes the brain to be highly susceptible to substances that disproportionately release dopamine and give reward. So this is a really important concept to get because the vast majority of people who have addiction that we treat have had a traumatic experience. Some more significant than others. Some maybe already had a generalized anxiety disorder, then they had a traumatic experience, and so it's amplified. So to us, maybe it doesn't seem like a big traumatic thing. But for them, because it was amplified by that baseline generalized anxiety disorder, or that self-doubt from their major depressive disorder, it may have been amplified to the point of solidifying in that central bed nuclei of the amygdala as a memory that will not go away, and then it will very specifically be set off in the fear center. And the reason I talked about the optic nerve tract is because what are one of the most effective treatments for PTSD that we have, especially single incident PTSD? EMDR. EMDR basically works by decoupling through the optic tract, decoupling that memory in the central bed nuclei from the connection in the fear center in the lateral bed nuclei. So what you're doing is you're decoupling the automatic taking of that memory and setting off the fear response in the lateral bed nuclei. Because when I first saw EMDR, I'm like, this is crazy. This is all placebo. It makes no sense to me, which is why I now know all that stuff, because I had to understand why that worked. And I think that's my ultimate theory, and I think we have some good functional MRI data to show that. Now, that ultimately what we're doing with that therapy, which is where we do a visual distractive event, we have them think, we have them talk out loud about the event that had occurred, and because they're distracted, it doesn't automatically set that off, and they now start to correlate the memory with a non-noxious event or thing. So this is a really important stuff to understand, because when you try to talk a patient into EMDR or into dialectical behavioral therapy or, quote, go to therapy, if you can't explain it, they won't do it. So understanding how this works becomes really helpful in getting a patient to buy into the realities of what will get them better long term and sustain the gains that we've created. So who saw me when I was here last year? All right, we have a few. So you're going to get a review here, but I still feel like it's an important part of this lecture to dig in on the neuroscience of addiction. So we need 3 things to survive, right? You need food, you need water, and you need dopamine. Yes, my super nerdy friends will say, you also need oxygen. And I'm like, yeah, you need skin too. But we're going to focus on this food, water, and dopamine piece, just to really understand about what that is. And the reason that dopamine is on there is because dopamine is the core source of our motivation. So if I say the word motivation, you should always think dopamine. And if I say the word dopamine, you should always think motivation. They are undisassemblable. You cannot take them apart. You cannot be motivated without dopamine in the nucleus accumbens and the ventral tegmental area. You cannot. You cannot pull yourself up by your freaking bootstraps if you don't have dopamine, right? So so dopamine is fundamental to just every aspect of our life. When I got up this morning and got out of bed at 4 a.m. in LA, I was like, all right, it's going to be a great day. I got an hour and a half drive on the 405, get to the airport. It's only 10 miles away, but it was still an hour and a half. I could have run there faster, but a little sweaty for the airplane ride at that point. But when we look at this, that takes some baseline motivation, right? It takes the normal, every day, I have to wake up, I need to go get that first cup of coffee, and my second, third, fourth cup of coffee, wherever I can find it, and then I can get on and we can do this, right? Well, we actually know how much that is as far as dopamine. We know that that dopamine release in the nucleus accumbens sits at around 50 nanograms per deciliter. And this was evaluated for micropipetting stuff that was done in animal models, and then they did functional MRIs on the animal models and looked at density of release based on total amount that was there, and then they were able to correlate that into the human fMRI model. And we know that fMRIs are not perfect, but they're pretty good, and they're actually getting much better with the machine learning algorithms that they're putting on there to get better resolution out of them now. So the data here is probably plus or minus, obviously, on the numbers, but it's within this range of about 50 nanograms per deciliter. That's what I need to get up and get coffee, right? The day I am not going to go to work, the day I'm going to skip meetings and hit decline on all of my calendar and sit in my basement and play Xbox, or fake vomit on the phone so I don't have to go into work, right? Whatever it takes to not have to do work that day. Like, I can't make it, just whatever it takes to get there. That's about 40. It's about 40 nanograms per deciliter. That's the low motivation day. That's the I need to take a mental health day, and I'm going to finally use that PTO that I haven't used, and I'm doing it today. That's that. So what about best day ever? Right? The day you win the lottery, own an island, and have 2% body fat all at the exact same time. Just boom, all happens. Well, it's about 100 nanograms per deciliter. Right? So this is the range that we're supposed to live in. Our favorite food, when we look at that, that's about 94 nanograms per deciliter. Sex, about 92, kind of a bummer. But oh well, maybe they need to redo that study, but we'll figure that out. There you go. But when we do this, that's where we're supposed to live. You have good days and you have bad days. You modulate on your motivation. I'm an editor of a couple of texts, and I can tell you there are days I am not motivated to sit down and read 300 pages of someone else's writing and fix split infinitives and look for passive tense. And there are just days I'm not motivated for that, and it's most days. But some days I am, and I get it done. So we all live in this pathway, right? Some people live a little higher up here. Some people stay in the 70 range. They're like, it's Monday, and it's awesome. And I'm like, I hate you all the time. And then there are the people that are the Eeyores of the world that are just like, I don't know. I mean, I just got a raise, I guess, but whatever. I mean, we know these people, right? You give them a brick of gold on Tuesday, they're going to bitch that it wasn't on Wednesday. Right? I mean, this is that group, right? So we all live somewhere along the motivation scale and the baseline dopamine release scale. But that's where we're supposed to live. That's where we're supposed to be. Bad days, good days, hopefully more good than bad. If you're sitting in this room, you've had more good than bad. Right? Generally speaking, we've had some extra motivation. There are days that we don't have it. Some of us have burned all the way through it, and so we've lost the capability to continue making it. But at the same time, we generally live above that 50%. We live above that normal one. To go through all of the school, to go through all of the testing, to go through all of the scrutiny, we generally live up there. So it's hard for us sometimes to imagine what it would be to not be there, to step into somebody else's brain, so to speak. And so as we look at what is happening inside the brain of someone who has used a substance like methamphetamine, that takes that dopamine from 50 or 100 up to 1,100 nanograms per deciliter. Or heroin and oxycodone that push it up in the 900s, and alcohol in the 800s, and marijuana in the high 600s. And all of these things, the body that we know does not like to be told what to do. We know that, right? It likes homeostasis. It likes to be where it needs to be. It likes that 40 to 100. It prefers the 40 to 100. So what it will do if you continue to use that substance is decrease the amount of dopamine released, then the amount of dopamine produced. And then over time, it will atrophy the neurons. And then we have some good data now that shows for at least methamphetamine, cocaine, and opioids, we probably end up having apoptosis of those neurons, which is programmed cell death. So there are a subset of the population, and we're still not sure of the density of this. We're landing somewhere around the 35 to 50% range of the population with a substance use disorder will not regain the capability to make static amounts of dopamine again. They won't. The body won't crank it back up. It won't just modify. It had a stroke in the happy part of the brain. those neurons do not regenerate. It is an old part of the brain, and that old part of the brain is highly protected. And it's protected by lack of change. So if we don't wire it well early, it makes it a lot tougher later. We know this from all of our pediatric science and stuff that we look at, that if things go really, really bad early, it's tough to undo that. And sometimes you just can't. Those wires are underground. I mean, they are really difficult. We can mess with the stuff in the outer cortex, like the orbital frontal cortex, lateral habenula. We can maneuver that. We can rewire that pretty easily. But the old part of the brain, the reward center, if that gets ripped up early, it is really impossible. It is the wiring under the 1800 street of brick that they put asphalt on that they then poured concrete over to try to get to it to make it change. It is important to understand that. That is why some people are just the people that they're going to be. And what we can do is manipulate how they work within the world around them so that they're not dangerous and they're more accepted and they feel more comfortable, but we can't necessarily change who they are, especially what it does around the reward center. So if we look at this, this is a problem when the best day ever is dwarfed by a pretty commonly found drug. You guys are probably, it's projected in the next 3 years, going to have more people using methamphetamine as their first illicit drug before heroin. And that's happening in a number of other states. Southern California is basically the same, where San Diego still has an opioid problem, but they also now have a significant methamphetamine problem. And then you know what? Then it'll be something else. I mean, the next big one is marijuana. I mean, the mental health disorders that it's causing already that we're identifying and the increased admission rates and things like that, these are problematic and we don't have the system to deal with it. But it's not a mortality problem, it's a morbidity problem. So we're trying to solve the mortality problem of opioids, and if we're not really thoughtful, we'll forget to actually build a system that can absorb the morbidity problem that we're going to get with these other substances. And then we always have the granddaddy of them all, alcohol, which has quietly been ticking up in the amounts that people drink on a pretty regular basis. I work in a profession that's pretty high stress. I talk to some of my colleagues. I spend a lot of time in C-suites of hospitals and other places, and when I talk with leadership, they all drink way too much. I find myself halfway through most of my gigs doing brief interventions every other day, more so than like talking about lean processing. This is a reality, and we know that this occurs and we see it, but it's a fundamental piece of kind of organizational trauma that we see that makes it super easy to now not be so angry at your job if you go home and have 4 bourbons. I mean, that's a reality. And if we talk about, organizational trauma is its own issue. But then if you treat this population, secondary trauma is occurring to us. You know, we can either create or destroy energy. We can just change its form, right? I mean, it's a fundamental, law of thermodynamics. I mean, it's just the thing that we know. So that's a physical law that we know just generally can't be broken. And because of that, if I spend all day giving energy to someone else who has low dopamine, I might as well have sucked the dopamine out of my nucleus accumbens and literally injected it into theirs. Because when I was getting home after these long days, I was done. I had nothing left. The empathy tank was fully empty, right? I had nothing to give to family. I had nothing to give to my kids. I had nothing to give back to myself. And so the field of medicine in general, when you take organizational trauma and then you take the secondary trauma that we get from patients when we do a good job with them. In fact, this hurts you when you do a good job. If you do a bad job and you create this iron shield around you that I'm just going to do medicine and nothing else, you're actually pretty protected from this. But you do a crappy job and you're kind of an a-hole. So ultimately, you have to decide what parts of yourself you're willing to give up to someone and give those freely. And recognize that we have to learn to compartmentalize. I would say anybody who sees this subset of the population on a regular basis should get their own therapist. And I'm not joking about that. I mean, you need someone who can help you fill your tank, a little bit, and not have to have it be your spouse, and not have it have to be your kids, and not have it have to be, a substance. So it's important as we go through all of this, we are not immune, to trauma. We see it every day and we deal with it every day. It's just different than the way that we've thought about it. So if we look again back at the brain, addiction modifies a lot of structures, but the ones that it focuses on, the final common pathway for addiction really does sit kind of in this connection between, for opioids especially, the periaqueductal gray, which sends out more endorphin, it decreases your overall endorphins, but it acts like that signal from the periaqueductal gray, so it binds to mu receptor, sends that the signal to the ventral tegmental area. That goes to the nucleus accumbens. It pumps up dopamine. Each drug causes the release of dopamine a little differently. Some will cause it as a signal coming from the ventral tegmental area. Some will cause it from the shell of the nucleus accumbens. Some will release it from the core of the nucleus accumbens. Marijuana releases it from the shell of the nucleus accumbens, which is why N-acetylcysteine is effective for decreasing reinforced use on marijuana, because it actually blocks the signal from the to the shell of the nucleus accumbens for marijuana. So it's got this interesting pathway. And N-acetylcysteine, everybody know that drug? Mucomist. We use it for Tylenol, acetaminophen overdose. Well, oddly enough, they were trying to use it as a control in a functional MRI study because they thought it had no properties in the brain whatsoever, and they were using it as kind of their placebo injectate because it was the same color as the one that they were using. And what they found is it actually blocked this signaling from the shell of the nucleus accumbens. And now we've had meta-analyses level data for adolescents where it's always been a positive outcome. It decreases total daily use of marijuana by almost 60% consistently and leads to a statistically significant difference in cessation. So why aren't we prescribing this? Well, because you can't prescribe it because you can get it on Amazon for $40 for 3 months worth because it's seen as a nutritional supplement out in the oral pill world. And we know pharma's not going to spend $200 million to get an indication for it when it's basically free on Amazon. So these are just things that we have, but the data's there. We were giving out, I bought like a vat of it and kept it in our thing, and we would give out baggies of N-acetylcysteine to our patients to take just because it was that cheap. So this is what we see. If we add in, a whole bunch of opioids, we get that there. We add in this release of signaling from the ventral tegmental area to the nucleus accumbens, releasing mountains of dopamine. Again, methamphetamine, 1,100 nanograms, heroin and oxy up in the 900s and all that. And then we increase that signal going to the amygdala, and specifically the part of the amygdala that's catching that big signal is going to be that lateral bed nuclei, but also the emotional, very happy memory of using that drug, especially when it filled a traumatic gap. When it made you feel better, then it lives in that central bed nuclei of the amygdala. And the interesting part of this is that lack of that signal stimulates the fear center in the lateral bed nuclei of the amygdala. So basically, when they start to go down on dose, but even before they have withdrawal symptoms, they have this fear, anxiety reaction that spits off in the lateral bed nuclei of the amygdala that is no different than a PTSD reaction. They are scared to death that they're not going to have it in their system, and they start to look like they're in withdrawal, behave like they're in withdrawal before they're actually in clinical withdrawal. And they're scared to death. And if you talk to people who have an opioid use disorder or heroin use disorder, and you ask them, what is your biggest fear? It is withdrawal. But I will tell you, the more that I've seen this, I did street medicine in Camden, New Jersey for a couple of years, and I would see people, I got to see them at many stages of kind of where they were in this phase, and when you ask these questions, it's really interesting what they'll tell you. Because I'll do a COWS on them, a clinical opioid withdrawal scale, and it's basically zero. There's no indication physiologically that they have it, but they are scared to death that it's coming, and then that changes that next value proposition of I got to get drugs is the most valuable thing that they can do at that point, and then the default reaction to that is to go get them. So as we look at how this is laying down tracks both in the old part of the brain and the changes it's making, and then in the new part of the brain and the changes that it can make, it really gets complicated. And then you have the suppression of the locus coeruleus, and as we know, if you take away opioids, you have opioid withdrawal. 98% of that is purely driven by the norepinephrine coming from the locus coeruleus, which is why we can give clonidine and lofexidine, one of the new meds. Well, new, it's been in Europe forever. It's just new for us. We probably won't use it for a while because it's so expensive, so until it comes off patent, it's going to be hard to use, but it's a great medicine because it does what clonidine does, but it doesn't knock you out and crash your blood pressure. So this is what happens in the brain. But after time, again, we don't produce dopamine, we atrophy the neurons, we decrease the capability for those to even live sometimes, and this is what we end up with now, where your best day ever is 20 nanograms per deciliter. Your average is about 12 to 14. and your worst days are 7 and 8, and you don't leave the house. You lay in your own urine. You cannot motivate to get out of bed to take a shower or go to the bathroom. This is also one of the major proposed mechanisms for catatonia, is a complete lack of central brain dopamine. And as we start to look at this, those features look a lot alike in some of my patients, especially right after they've gone through a withdrawal episode and are not being treated for their disease other than being held captive, right? This is common in my criminal justice population, so when I will go see people in jail or in prison, right after, they sit at this low phase, and that actually puts them in a position to be very vulnerable to more trauma to occur inside of the jail or the prison. And as these things go down, if I don't have dopamine, I don't have what? Motivation. So the patient population that I treat, with pregnant and parenting females, they have a baby, they pull the baby, put the kid in foster care, they got a family court, mandated to go to treatment. But then they have to do all the family court stuff. They have to do all the paperwork that goes with that, which, by the way, is a mountain of paperwork. Then they have to do all the treatment stuff, because normally they put them in IOP, intensive outpatient. And so when they do that, that's up to 17 or so partial hospitalization, get up to 23 hours per week of treatment. So you have to motivate to go to this treatment. You have to motivate to go do all of this paperwork. But yet I have someone whose dopamine is in the toilet. It's half of what it was when I threw up on the phone so I didn't have to go to work. Right? And then we're expecting them to do this Herculean effort. And if they're not perfect, they lose their kid. So in lieu of perfection is loss of child. This is weird. I am pretty sure we don't do that with diabetics who have really poor glycemic control and can get a little dangerous. Right? We're not like, we're going to pull your kid. We're like, we're going to teach you about calories again. Right? We don't fire those patients from our practice because they ate a box of Krispy Kremes. We usually ask them for one. Or at least I do. So as we start to think about what this looks like, we start to be able to begin to predict, again, the behaviors that we see. Because I can't look into everybody's brain when I'm seeing them, well, anybody's, to be honest, but at the same time, if I understand the mechanisms, then it helps me to really understand why the behavior looks the way that it looks, because that's what we interact with the patient, is the behavior. Some of these behaviors are crazy, right? They seem so off the wall. Like they'll go in the emergency department. I'll have people, when we don't give them pain meds, like just completely lose it and like pull stuff off the wall and like raise a ruckus and scream and fight. But what do we do with them in the emergency department if they do with that? Sedate them or just let them leave AMA? You're like, look, you can leave, bro. Good luck. Have fun. Next patient. The way it normally goes down is the doctor tells the nurse to let them go AMA. Never physically walks over to the room where the patient is having their little moment and never does any de-escalation. They either call the nurse to do it or they call security to do it. But pretty cowardly approach from the doctor's side in most emergency departments. And I work as a locums doc now, so I work at a bunch of different hospitals in different states, and some are kind of urban, some are rural when I pop in and work. And so I get to watch these behaviors without having to ever really talk. And it's great being locums, because you just show up, and as long as you're safe and see patients and you're kind, they just leave you alone, man. They're just happy you're not crazy. Because that's, in a locums, you get one or two people that can't hold a job, so they have to do locums, or people that already have another job and they just want to do locums. And so they very quickly try to figure out which one of those you are. And it's really the nurses that determine whether or not you continue to work there. It's not the other doctors. The other doctors are like, I got other patients to see. Whatever that dude's doing, he's doing. But at the same time, as you do it, you can sit quietly and you can watch these behaviors. And now, I've identified pretty standard behavioral approaches, and I've gotten to where I can almost like mind meld with these people and say, I know that you drink too much when you go home, and I know that you had early life trauma based on the behavior that you've had with your patient. So I know that this behavior is going on. I know your orbital frontal cortex has been maladapted to think that a value is praise from the nurses rather than patients. That is a warped sense of a value as we go in here, because the nurses will praise you when you move the meat in the emergency department. The patients won't. So we have to think about even how we're utilizing these default behaviors associated with our values that we've put into that orbital frontal cortex. And many times it's for protective reasons, like we talked about, to try to keep ourselves from having to go home on a fully empty tank. I don't know how people work in medicine their entire career, full time. I don't. I really don't. I see very few people who do it well. I see a lot of people who do it, but there comes a point in which they're basically phoning it in, and it's automatic behavior. They have the same spiel that they say to patients. They have the same thing. It's protective. If we don't do good self-care, which is not really a part of what we're talking about tonight, but I'm telling you, if you don't, you can't be good at your job. I've seen a lot of people just be kind of emotionally numb as they walk through the rest of this stuff. And it's important, if you understand these behaviors, you can then begin to understand how your own behavior really is just transference from the history of trauma that you've had with these other patients. Because many times we walk into a room ready for a fight because it's that patient and that person that we know. I always tell the nurses at the places, I go, don't ever give me the history of a patient unless it's because they have an LVAD or they have some really random rare disease. I don't want to know their old behavioral patterns, because what I don't want it to do is taint my approach when I walk in, and you can't help it but let it do that. So I just don't even want to hear it. It's like, la, 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 because they'll tell you, well, this person last time she was here, she's a drug seeker. You know, they say that stuff all the time. Well, let's think about that. If you don't have dopamine, you have craving. That craving, again, is craving that dopamine. And that craving, that dopamine, the default value is the drug. And if it's opioids, then it's hydromorphone, because that's the one that you can get in the emergency department that if you push it IV, it feels like heroin. So that drive to get that drug, the drug that starts with a D, I call it Dolobid, and they're like, damn it. You know, Dolobid is an anti-inflammatory European medication, but they don't know that. But they flip into survival mode, and that survival mode really explains what we see for a lot of the behaviors that we see. And then at the end, we have the primal action, the pulling the paper towel thing off the wall, you know, the throwing stuff around, the screaming, the yelling, the temper tantrums, the things like that. We can really walk them through the neuroscience of why they've gotten to here. But if the lower their baseline dopamine, the more scared they are, and the more apt they are to have a fear-based response and do these things and escalate. So behavior should not be a frustration. It is a symptom. The worse the behavior, the sicker the patient. If I walked out and I see somebody telling me they have belly pain, but they're eating hot Cheetos and they're like watching their phone, like whatever, watching YouTube on their phone, they're looking no distress whatsoever, that is a person who I probably don't need to rush to the operating room, right? We can look at that person, we kind of get a clinical picture from that. We see a person who is sitting there with a rigid belly, doesn't want to move at all, and they're like, they don't want to, we're like, oh, that's an acute abdomen. That one needs to go to, I'm not CAT scanning that, I'm calling surgery. And they're going to come down and evaluate it. And then they can order the CAT scan that we don't need. But but when we look at it, this is what has to happen. And we do this all the time. We do it for all the patients, no matter what kind of medicine you do. You know, you look at your patients, you have a pattern that you see. Somebody clutching their chest, they're diaphoretic, they're pale, they're nauseous, they're 60, and they have a history of an MI. Wow, that's a no-brainer, right? I mean, those are pretty straightforward things. Behavior in a patient who is, quote, drug seeking that is that extreme is the 60-something-year-old person clutching their chest that is diaphoretic, because the mortality rate of the untreated addiction in that person is exactly the same as if we missed the heart attack. At 90 days and at 1 year, it is a missed heart attack, but yet we routinely just let them walk out. We don't talk to them, we don't interact with them, and we don't de-escalate them. We don't give a crap about them, because it's hard. It's really, really difficult sometimes in a long shift, a long week, a long career, to really pull it together. There are, however, techniques to do it, and I'm loved now when I go back to the emergency department, I never get complaints. I haven't had a complaint in years now, and in fact, I have patients that will come back to my next shift because I'll talk to them and we'll start them on buprenorphine, and I'm like, do you want to start therapy? We can get you connected with that outpatient. I can write you a script to give you a bridge, and we can get you there. Some are not ready, about half. About half are just not ready at that moment. And then I say, you know what? That's fine, I get that. Good news is that drug lasts for a little more than a day, so you can think about it. You're not going to be craving, you're not going to have withdrawal, you're not going to have to worry about it. I'm here tomorrow, so if you want to come in and go. Half of those that leave come back. I mean, so this is just an easy conversation. It actually makes the job happier. I leave my shifts happy. Now, I only work 3 to 4 shifts a month, so that's probably... It's easy, right? It's easy to be like, oh my God, I'm a doctor. This is amazing. I get to heal people. Because it's not the 20th shift in the month, and a swing on a weekend on a holiday. But the reality is it does make that deflection and that capability. Because when I do work there, all I pick up are those patients. So they love it when I work now. Because they're like, I got a perfect patient for you. I was like, yes. And it's the patient nobody else wants to see. But it's really fun if you understand why they're behaving in this way. So let's talk about, the behavior by itself is really well understood to the point where we basically define addiction based on behavior. And the behaviors are so predictable, we only need 9. So we look at 9 behaviors associated with how they obtain or use a drug to help us identify whether or not they have addiction. Right? It's not 1,000 different behaviors, it's 9. And so when we start to look at these things, the criteria that we use to describe addiction is pretty straightforward. It's all of the behaviors associated with craving, low dopamine, and this primal action. This change in the orbital frontal cortex assigning value, this change in the lateral habenula for the default behavior when given a situation. These are the things that we should just understand and just be okay. These are neurobiological changes that have occurred that, unless intervened upon, are not going to change. Right? They're not going to, if I don't unclog an artery that's causing a heart attack, it's, generally speaking, not going to unclog itself. It is no different here. If we don't do the right therapies and stabilize dopamine, it's not going to change. So let's talk about craving a little more, because this is always a little bit gray. So craving is basically a direct or an indirect force pulling someone towards a substance or a behavior, this need to do that, whatever that may be. Everybody has their own stuff. They have their default. If we're lucky, our default is like, man, I got to go for a run, right? That's a great default behavior. Unless, of course, you're running 30 miles a day because you just need that default behavior. But if you look at water, and we talked about food, water, and dopamine, we need water to survive. So there were studies that were done that were looked at evaluating what does the craving look like in the brain for water when you haven't had water for 3 days. So they took nothing orally or IV for 3 days. Most of them met for severe or moderate orthostasis and dehydration when they would check it. So their vata, that means they would stand up, blood pressure would drop, pulse would go up. I'd like to have heard the IRB discussion on this one, but it was pretty interesting. But anyway, they shoved them into a functional MRI, sprinkled water on their feet, played water sounds in the background, let them taste and spit out water, talk about their favorite thing to drink, and then they functionally MRI'd their brain. And they found that the places responsible for craving had a signal about the relative size of a baseball, right? And then they did it for food. They said no food for 5 days. All they got was just enough liquid to do maintenance fluids only. No caloric intake. And at 5 days, they shoved them into the functional MRI, and they said, let's talk about your favorite food. And then they actually brought their favorite food in and wafted the smell into the MRI. They had them taste it and spit it out, and then functionally MRI'd their brain. Like, all this, like, it's amazing what you can do to medical students, right? But they did that, and what they found is the relative size of craving in the brain was about the relative size of a basketball. Now, if people are dying of starvation or dying of dehydration, they'll do some crazy stuff, right? They'll steal from people. They'll take from family members. They'll take what they need to survive and let somebody else die. People will get into that level of a survival mode. I mean, like if I walked across the desert for 3 days, right? I walk across the desert, I get to the end, I haven't had anything to drink, and there's this beautiful glass of water sitting there. You got condensation coming down the sides. I go to grab it. Somebody steps in front of me, and they're like, no, that's my water. I'd be like, okay, stab. And then I would move them out of the way, and I would drink the water, right? And I would do that, and the funny thing is most people would be like, well, that was an idiot move for that guy to stand in front of the guy who's going to die of dehydration. I'm like, I would have stabbed that dude too. We can justify that. Somehow internally, we start to justify these really extreme behaviors when people are trying to survive. So then we looked at patients, we, the collective, really smart sciencey, we, other people, not me, did this work, and what they found was if they took people for opioids and alcohol and scanned the brains when they had been off of those drugs for 30 days, 60 days, 90 days, and then 6 months, 1 year, 18 months, and 2 years, it was interesting because they put them in the functional MRI, and they had them talk about the first time that they used the drug and the last time that they used the drug. They weren't like sprinkling fentanyl on their legs or stuff, but they were, they had them do it, and then they had them imagine they would show them drug images, on videos, and then functional MRI of their brain to see. Now, I'm only going to talk about 30 days and 18 months because everything between 30 days and 18 months looked exactly the same, except it actually continued to increase until about 1 year, and then it slowed down the increase, but that it didn't plateau until 18 months. So for 18 months, these patients had basically worsening craving when they talked about, heard about, or saw pictures of the substance, or even talked about the locations that they had used the substance in. And the relative size of craving in these brains was about the relative size of a baseball field. It was logarithmically bigger in intensity. And the voxel morphology that they looked at as compared to when we're going to almost die, we're worried about dying of dehydration, and we're worried about starvation, and our body is craving calories and craving calories. And so this was just a loud siren in the brain, and they actually found as a secondary outcome for these studies, the amount of signal that ended up going to the medial prefrontal cortex was cut in half. So this made them really work off of the primal part of the brain, the id, the part of the brain that is, if it feels good, do it, survival only, me first. I'm not thinking about my kids, I'm not thinking about my parents, I'm not thinking about my siblings, I'm not thinking about my friends. It is survival and it is me. This is not a choice. This is not a bunch of good inputs into the medial prefrontal cortex doing a pros and cons list on a refrigerator of shooting up heroin on a Sunday morning. It is not. This is a reaction to a profound noise in the brain that has a drive bigger than starvation and dehydration to obtain a substance that actually, for them, is the most valuable thing in their life at that point. And the default behavior is to do anything they can to get it. And we treat that by kicking them out of healthcare. So, as we look through the neuroscience of the trauma, and we look at the ways in which culture play a role in this, and the ways that how trauma sets up this whole pathway for addiction to be more profound, more easily obtained, and then structurally just laid in as a track, and a very predictable one at that. What we find is a whole group of things that we don't do. What percentage of primary cares screen for addiction? Routinely, everybody. Like use a validated verbal screening tool. About 10%. How many do an assessment? Of the ones that screen, how many then follow that with an assessment? Only about 10% of the 10%. So yeah, about 1%. And how many of them do a level of care determination? Yeah. So this all leads to what we have to be able to do for this, but I think that if we didn't have, I felt like it was more important for me to talk about the stuff that it's not easy to find, because there are adaptive realities that we have to change, and there are technical realities that we have to change. Technical change is pretty easy. We do technical change all the time in medicine. There's a new medicine out, there's a new dosing regimen, there's a new insulin regimen. That's stuff we onboard in 2 seconds. There is not one doctor that I know that works in primary care, works in the emergency department, works as a hospitalist, who can't read about the pharmacology of buprenorphine and write a frickin' script. This is the reason they're not writing it has nothing to do with it's so hard. Right? You can take a bucket of that medication and you won't overdose. There's not one overdose case report in the entire country. There's only one in France, and it's questionable because they also found benzos in their system of the overdose from buprenorphine as a monodrug. So that's it. So we have to screen, we have to assess, we should be doing level of care determination. We do this for every other disease. If somebody comes in and they're diabetic and they look like crap, we do a quick screen, we do a blood sugar, oh, that's high. Now I need to do an assessment of what that means. Does it just mean that they have a high blood sugar, or does it mean they're in DKA? So we assess that, and if we identify that they're in DKA, we have a set of criteria that tell us what level of care they need. They need an insulin drip. That insulin drip needs to be monitored in an ICU, and they're placed there. We do it for everything else. It's no different in addiction. So what does MAT do? So if we think about that whole behavior and the depletion of dopamine, For opioid use disorder, buprenorphine and methadone, all it does is stabilize dopamine. It just does it in a very predictable way so that you don't get peaks and valleys. So when you take methadone, it takes that dopamine back up to 50, between 40 and 70. They don't get intoxicated from this. These are long-term medications. Now, people can boost. They can go drink alcohol, or they can use other meds on top of this. The most common one here is they'll smoke weed on top of their methadone, which basically makes them intoxicated throughout the day. So we have to be cognizant of that. But the medicines at their core just stabilize dopamine. It just does it in a way that's predictable and safe. So when we put people on these medicines, we have methadone. It's been around since the 70s. It's got significant effective rates. I don't know if I put that slide in, but I'll just say it quickly. Methadone is 70% effective at maintaining in treatment at 1 year, on average. So there are better programs and less, right? What other things do we have that keep people in their treatment for 70% of the time? What are our rates for active continued treatment for hypertension? No, it's like 48 to 52%. Diabetic management, same. We hit around the 45 to 55% range for all chronic diseases, but interestingly, methadone treatment for opioid use disorder stays around 70%. And there are, at this point, 1,000 studies that show it. I mean, it's not a question. We've done it over and over again, every different imagination, every group, every pathway. Buprenorphine, this one can be prescribed. Take an 8-hour course as a doc. You take a 24-hour course as a PA, NP, or other APPs as well. And other advanced practice nurses and all that. And then with this one, it's anywhere between 55 and about 65%, depending on where it's delivered. Like, are you just writing a script and doing nothing else, or are you doing a good survey of social stability and all of these other pieces, and are they at the right level of care, all of that stuff, and you can get pretty good. We were at about 75% for retention rates at 1 year for our patient population, but we had fully integrated behavioral health with people that did real CBT, real DBT, and EMDR, and we did a fully trauma-informed approach to our patients. Naltrexone has been around since 2010, so it doesn't have that much. We have hundreds of studies for buprenorphine now. We have about 26 studies for naltrexone, so we're just still kind of in the early phases of knowing exactly where this fits in treatment. I used it a lot, but mainly for people who could produce their own dopamine. So if they were motivated, and if you look at the insert for this drug, it says works better in motivated patients. So motivated patients means that they're making what? Dopamine. So if you're not making dopamine, the other drugs are what you need. The less dopamine you make, the more likely you are to need methadone, because ultimately it's not the drug that's the big deal, it's the way that the intervention works, because you see them every day and you get it delivered, you're monitored, and it's closer, and buprenorphine will do that on the outpatient. If we use methadone and buprenorphine, we get all this stuff. A reduction in the use of illicit drugs, reduction in criminal activity, reduction in needle sharing, which means reduction in HIV. It's cost effective. We have a reduction in commercial sex work. We have a reduction in the number of reports of multiple sex partners. Improvements in social health and productivity, improvements in health conditions, retention and addiction treatment, reduction in suicide, reduction in lethal dose. Does aspirin do that? No. It just doesn't. Buprenorphine and methadone have been shown to decrease the 1-year mortality rate from overdose by 60%. A defibrillation for VTAC decreases mortality by what percentage? Well, it's about 22% for true VTAC, right? So that's enough of a mortality benefit that we mount these things on Burger King walls, and we allow a perfect stranger to shock another perfect stranger. And we're totally cool with that. We're like, AEDs, yay! We're fine with that. But somehow we don't feel comfortable putting naloxone on every street corner in just big buckets so that people don't have to die from their disease so we can treat it. So I'm going to skip to these, and I'm happy to chat with these, but I felt like the other stuff was there, and really kind of end on what does this ecosystem need to look like to get there? Because that's what you guys are going to talk about. And the ecosystem has to be all of these things. And again, all of these things exist for every other medical specialty. It exists for cardiology, for transplant, for general surgery. You have the different levels of care, whether it be outpatient or med-surg or a step-down unit or an ICU. But for us, we just call it outpatient treatment, intensive outpatient treatment, residential or detox, medically managed. There's sub-levels of care in there that do specific things at higher levels than others. We need to be screening and referring appropriately. So we need to go from that 10% to 100%. And then we need to do data collection and evaluation. I need to, in addiction medicine, to happen what happens in cardiac care, because in the emergency department, again, if I forget to give an aspirin to someone with a STEMI, I get a call the next morning from a nurse who's like, what the hell? I mean, you're a terrible doctor and you should probably be fired, but I need you to explain to me why you didn't give an aspirin. And then you got to write something. You got to document it, you got to do this. That's what we have to do, because an aspirin decreases the risk of death by anywhere from 18 to 24%, and we think that's really important in a STEMI, and so we have to be all over that. Social determinants in prevention. This doesn't mean like we have to fix poverty or fix housing. We just need to be cognizant that early treatment may depend on access to those things, right? And so we do this for other things. We put people in long-term care, we put people in SNFs, we put people in the Ronald McDonald House if they need it for that early stability of their disease so they can get treatment. We just need to think about it no differently for addiction and not feel like we have to say, what is the farthest thing away from the major industrial complex of the city that I can get property where NIMBY doesn't come into place? Clinical structure, bunch of different ways to do this, and then you got to pay for it, right? How do we get there? You build capacity. You build competency, you build consistency, and then you end up with making sure that all of that is compensated. Because if it's not compensated, it doesn't last. It can't just be a grant that does it. It's got to be reimbursed in a normal structure that we feel comfortable with. We need to be able to have episodic care payments, we need to have bundled payments, we need to do all of those things. We're working on all of that, and a lot of smaller places that fund their own stuff are doing that by themselves already at a very high level. But if we don't do this, then the vast majority of the patient ones will either have premature death, not only from overdose, but HIV, hepatitis C, infection, all this other stuff that happens. So early death, incarceration, or overdose. That's the final common pathway for untreated addiction. I mean, that's just it. But if you treat it, we can be really successful at it, because opioid use disorder is without question the easiest addiction to treat. It is the easiest addiction to treat. And we are terrible at it as a society of healthcare. And so we have to fix that because we have the data to do it. So culture really matters. Think about, what are the 5 things that define the people you see? Ask them. That's what I've done. It's pretty interesting what they'll say. And then actually change the system to add those in. Don't just be aware of it, but actually think about building the system with that. And so if we look at stigma and misinformation, are the biggest barriers to adopting MAT. And again, what did I call stigma at this point? Discrimination. It is. We identify a label, and they get something different because of that label. They get something different than somebody without that label. We are actively discriminating against them. Every CEO that doesn't institute an MAT program in their healthcare system is a discriminatory person. And I make that statement very loudly and just as a reality. Prove me wrong. So we have to hold each other accountable for doing good work for the communities in which we live, in the schools that our kids go to, in the places where the rest of our family lives. If we can't do it in a community, especially one that's relatively close-knit like this one, I don't know if we can do it. Because I'll tell you, trying to do it in LA County, where there's 11 million people, is complex. I like coming to communities of this size because it's complex in its emotional capabilities and stability and the way to work together. But you don't have as much infighting. You can just do the work. You can sit down and have a conversation. It's like a new company, right? It's like an agile company. And you can do all of these things and actually lead the way so that places like Chicago and like LA and New York can actually just learn from what's being done and implement it rather than having to implement this. So with that, I'll stop. But I think that you all have the capability to do this work well. To do it is just a part of your normal daily routine. And then without question, you will have such an emotional reward on the other side if you treat these patients. It's hard to describe. I would ask you to identify someone in your community that does this and just ask them the question of job satisfaction. Because I will tell you, I have not been the happiest in medicine until I started treating these patients, because it is simple and easy and life-changing. Thank you.